Hi, this is Dr. Bob Dannenhoffer, the Public Health Officer from Douglas County, with our update for December the 8th, 2020. I'm in the room all by myself, so I can take down my mask, thank goodness, and we can chat about what's going on. So again, Dr. Bob Dannenhoffer, the Public Health Officer from Douglas County. This is our chance to answer your questions, so please let's do that. So you can put them in the chat section. We also got some very excellent questions in through the Facebook questions at douglaspublichealthnetwork.org. Again, that's Facebook questions at douglaspublichealthnetwork.org. And we'll do those first, and then we'll get to the questions you have. As always, let's start off with how things are going with this, and it's not going so great. This is a very active pandemic, 67 million cases, over 1.5 million deaths. It is we're seeing now in the world the highest case counts and the highest death counts we've ever seen. Still a very active pandemic in the U.S., in India, in Turkey, in Russia, Brazil, Italy, the UK, and Germany. But the U.S. by itself has almost as many cases as all of the other countries I've mentioned combined. And in those cases, only Turkey, Brazil, and Russia are still seeing the steep increases that we are. Most of the rest of the world, especially in Europe, had a big surge in October. They instituted some changes, and they've seen a decrease in the number of cases. In the U.S., we're over 15 million cases, over 290,000 deaths. 35 states the other day, 39 states today with over 1,000 cases. And really, I think at this time, you'd only say that Hawaii and Vermont have this under control. Really, every other state is not really under control. We've had a 7-day average of 200,000 cases a day, and we're averaging over 2,000 deaths a day. To put this in perspective, if you're a young, healthy person, your risk of dying from this is pretty low, but young, healthy people don't die very much other than accidents and occasional suicide. But young people don't die very much, but as you get to be 60 and above, you do start dying of things, and most of the deaths we're seeing in people 60 and above. And so when we look at heart disease and cancer, those are mostly people who are over the age of 60. And now COVID is the leading cause of death. So for December, COVID will be the leading cause of death. We've passed accidents in the springtime. We've passed heart disease and cancer. So COVID for December will be the leading cause of death for all Americans, not just for people over 60, but for all Americans will be the leading cause of death. There are over 100,000 people in the hospital, and the hospital systems in many other states are really being run ragged. So we look at Southern California, look at Idaho, look at Texas. The hospital systems are really worrisome. In Oregon, we're averaging over 1,500 cases a day. We have 600 people in the hospital, about 120 in the ICU. Remember, in Oregon, we had a relatively low case count until October when we started to have an increase in cases. And now we're starting to see the increases in deaths. Oregon reported 36 deaths just today. Wow. We're averaging now 18 deaths when we were averaging just 5 or 10. We're now averaging 18 deaths a day. And so these gatherings, which lead to cases, which lead to hospitalizations, which lead to deaths, are coming back to reap what was sowed. In Douglas County, we're over 1,000 cases now. We've had a varying number of new cases over the time. However, it is starting to come down. So 2 weeks ago, over the 2 weeks before, we had 294 cases. In the last 2 weeks, we had 238 cases per 100,000. So I think the numbers are starting to come down. And I think related to some of the observation that really this disease here is in Douglas County, and because of some of the things from the freeze. We're now at 25 deaths. So we, again, had not seen very many deaths before, but we're now seeing an increased number of deaths. The really good news of the vaccine, I'm sure we'll get to that later, but let me get to the questions first. So here are the questions from Facebook questions. So how will the COVID-19 vaccine be delivered to the outlying areas of the counties like the coast? Will it be sent here, or will people have to drive to Roseburg? What about older folks who have troubles getting out of the house, Katie asks. Really good question. So the vaccine is coming in 3 phases. The first phase is the 1A phase. The 1A phase is for healthcare workers, especially in the hospital, long-term care workers, and long-term care staff. Obviously, those people are working at the hospital or live in long-term care, so there won't be any travel at that point. The 1B group is going to be people for essential workers, and we think there are probably going to be places for the vaccine scattered throughout the county for essential workers. And then the third group, which is where most housebound seniors would fit, is going to be the 2 group. That's probably going to be in February or March. By then, we're hoping the vaccine will be widely distributed at doctors' offices, at pharmacies, at hospitals, and there may be some drive-through other kind of clinics. But we really think that this vaccine by February should be as easy to get as a flu vaccine. So if you now get your flu vaccine at the pharmacy or at the hospital or at the doctor's office, we hope it's going to be there then. So Stacy, this is a long question. So this is about with the introduction of the vaccine, we're still going to have to use masks, social distancing, hand washing until we get a lot of the population vaccinated. It is true. So really, people are going to have to use masks, social distancing, other kinds of restrictions until we have enough people in the population that when a case comes in, it won't spread. So think about this situation here where you have it where it is now, where about 95% of the people we think are susceptible to the disease. So somebody comes to a Thanksgiving party with a dozen people there. One person can spread it to 6 or 8 people at the Thanksgiving dinner. Those 6 or 8 people can spread it. Some will spread it to none, but some can spread it to 1, 2. Other people can spread it to 6 or 8. It's not until around the table there's only one person who's susceptible. That one person who's susceptible hopefully will not come in contact with anybody else who's susceptible, and the vaccine the disease will die out. So that's where we need to get to. But until we get there, we are really going to have to take this seriously. So she reports the thing that we could have 10 million more Americans contract the virus and more than 160,000 die. I think that is totally possible. I mean, with over 2,000 deaths a day, we could have 60,000 die just in January. And then as we get to February and March until we get the nice weather in the springtime, it really is a lot. It really is a lot of deaths we could see. And these deaths, when we look at them, some are older people who are in nursing homes. But as I look at the deaths and look at the birth dates of birth on these deaths and find that, dang, there are 6 or 7 people who have died in the last month who are younger than I am. So I don't feel particularly old. And so these are not people who were at the very end of life. These were people who were out at parties, and that's how they got this. Or they were out at work, and this is how they got it. So these are not people who are one step from death's door. Many of these people are people who are vigorous. So how long do you have to use the mask? I mean, I really hope that by next summer we can get our act together, get people vaccinated, not have a tremendous amount of disease circulating by next summer, that by next summer we can say, look, the good news is we've had 2 cases in Douglas County over the last week. The good news is we can get rid of the masks and we can open everything. Still want to be careful about big gatherings. Still want to be careful about some really risky events. But for the most part, you can get back to pretty much normal. So Linda says, can I explain a little bit more about the drive-through testing process? Does one have to have a doctor's referral? Can people with insurance come? So the story on the drive-through is this started very early, back in March, 9 months ago, when we started doing this. And we did this at the time as our drive-through because it preserved protective equipment. One person in one of those moon suits could be in the moon suit the whole time, and they wouldn't have to be changing masks and gowns and gloves each of the times. And so that's why we started it. At that time, the only available test was a deep nasopharyngeal swab. And then the test that they did on it was a polymerase chain reaction test, or a PCR test. We made a deal with Quest early on that they would supply the equipment and we would supply the tests. They would go ahead and do the test. They will bill the insurance or the feds whoever in the world is going to pay for this, but they would never bill the patient. And to their word, they have been 100% on that. But to do that, they were relying on some of the things that were said by the president, that if your doctor orders the test, you will not get a charge for this. So we have done 2,000 tests in that area there. Nobody's gotten a bill. And so the deal is you do need a doctor's referral, because if you don't have a doctor's referral, they cannot guarantee that you will not get a bill. Can people with insurance come? Yeah, we take anybody. Have insurance or don't have insurance. Do you need a doctor's order? Yes. And so if you have a doctor, that's the best way to do it, because then your doctor knows when he gets the result that, hey, I have this positive result. If you don't have a doctor, Aviva Clinic in Sutherland has agreed to go ahead and provide the doctor's order. So again, you will not get a bill, as best we can tell, for these tests. Now, with the new rapid tests that have come out, the new rapid antigen tests that are widely distributed throughout the county, more than 25 places in the county have these rapid tests. The rapid tests, back in March, the only test available was the PCR, so we were using it for all purposes. Symptomatic people, asymptomatic people who were contacts, and for people who needed to test for other reasons like preoperatively. It still is a great test for preoperative people. It still is a great test for people who need a very high sensitivity and specificity test, but it's slow. It can take 2, 3, or 4 days to get the results. So if you are acutely symptomatic, the very best thing to use is one of the rapid antigen tests. Those are a little less sensitive and a little less specific, but so much faster and cheap. So that if you're sick with the disease, we're really recommending the rapid antigen test, so you don't have to wait 3 or 4 days for the result. So is there a test for diagnosing illness that's being described as long haulers? No. So the problem with the long haulers is these are people who had diagnosed disease, who then you contact a few months later, you say, how are you doing? And sadly, the majority of people say, not so great. Shortness of breath when I exercise, still a lot of chest pain, still some people with loss of sense of smell or taste, a lot of people complaining of this brain fog where they really feel kind of out of it. There is no specific testing for that. Now, I'm getting the question is, I'm wondering how many people were affected months ago with undiagnosed and untreated COVID-19 and are now experiencing symptoms that could be debilitating. I think that's true. The question, should get a PCR and antigen test? No. What they should get is an antibody test. So this virus was not around until the fall of last year. And so that if you have antibodies to this germ, you have had the infection somewhere before this time. So the right test to see if you think you had undiagnosed COVID is an antibody test. If you use one of the high-quality antibody tests like at LabCorp, Quest, Mayo Clinic, Mercy, any of those, and it's positive, then you definitely had the disease. Nonetheless, I think this long hauler thing will be really a big problem later on, because many of these people are not going to be able to work. Many of these people are not going to be able to enjoy life. So this next question is a great question. Thanks so much for Facebook. Why is the death rate, number of those positive over the number of deaths in Douglas County higher compared to other counties? So if you look at the number of cases on the denominator and the number of deaths on the numerator, the numbers for the country are, there's 293,000 cases and 15.6 million deaths. So for a case fatality rate, so that's not an infection fatality rate, but a case fatality rate of 1.9%. In Oregon, there are 1,080 deaths over 87,000 cases for a case fatality rate of 1.25. And in Douglas County, we have a 25 deaths and 1,000 cases for a case fatality rate of 2.5%. Well, the case fatality rate is incredibly sensitive to the age distribution. So if you had a population where everybody was under 50, your case fatality rate, you'd still have a lot of cases, but your case fatality rate would be really very low because you have very few fatalities. On the other hand, if your population were all people over 80, you'd have a really high case fatality rate because the risk of dying is lower. So, and these difference in case fatality rates, again, 1.9% as the country, 1.25% as the state, and 2.5% as Douglas County, goes exactly according to the populations. So, for example, Lane County has a lot more cases and a lower death rate because they have tested a zillion students, many of whom have been positive. So they have a lot of cases, but very few of the students die. In Douglas County, we obviously don't have a big student population, and we have a big senior population. So I pulled the census facts today. So for the country overall, 16.5% of the people are over 65. Really, that's the group that tends to have a lot of the issues. In Oregon, it's 18%, and in Douglas County, it's 26%. So we have almost twice as many seniors as the national average, and so that our death rate is a little higher than the national average is exactly according to expected. So when I did the age-adjusted case fatality rate, our age-adjusted case fatality rate is just exactly what you'd expect. So that is a great question. So somebody said the thing about ivermectin. So ivermectin is an anti-parasitic drug. You can use it to treat heartworm in dogs. We use it to treat certain parasitic infections in people. And the drug has been around for a long time. And it's really quite safe and really pretty effective. And in the rest of the world, very cheap. I was going to look up how much it costs in the U.S., but in the rest of the world, very cheap. So there have been people who have been very interested in using ivermectin because there are a couple of early suggestions that ivermectin works. So they're like 2 cents a piece in the other countries. They're $8 in this country, but still relatively inexpensive. And so, the little bit of data, the anecdotal data is that ivermectin seems to work. There's one small sort of controlled study in Egypt that suggests that it works. And so I've been in medicine a long time. And every year, even before COVID, there's 10 articles like, oh, this is going to be the greatest new treatment for cystic fibrosis, or this is going to be the greatest new treatment for autism, or this is the cause of SIDS. And so you read these articles, and they're based on small data sets, and the people are absolutely adamant that they have found the answer to a long-term problem. Most times they're not right. So, of the 10 that you see a year, only 2 come out. And so with COVID, we've seen the same thing. So let me give you the list of drugs that's been said that works. Right? So hydroxychloroquine, been studied extensively, doesn't seem to work. Remdesivir was going to be the miracle drug. It seems to help a little bit, but not very much. The monoclonal antibodies, again, really hyped as going to be the miracle. They seem to help a little bit, but they're certainly not the miracle that people had thought. Luvox, which is this drug that we use obsessive compulsive disorder, a small randomized study that showed that it did seem to work. And ivermectin is still there. Some experiential studies, some really small studies to suggest that it works. There is going to be a really good randomized double-blind control study that started in October. We should know about the answer soon about whether it really works or not. And so this is how we learn things in medicine. You start it with observation. You then try to hone down your observation. Then you do a real study where you do with controls, and then you get to see if it really works or not. And again, you start with 10, only 2 in the end really work out. So the answer is ivermectin is right in that I don't really know whether it's going to work or not. You would think if it really works so great that somebody would have been able to pull together a good controlled study within a month or 2. I mean, it's not like we're lacking for cases. There are plenty of cases of disease out there and would have shown that it's going to work. But I would say that ivermectin is interesting, but the data is not in yet. Daniel asks, can you talk about treatments that people in Roseburg are getting once hospitalized? Are there treatments part of those proving to have success? And the answer is yes. So for our number of hospitalizations, we have a relatively low death rate in hospital here. Now, in Oregon, many people choose, they're faced with critical care or go home to die. Many of them choose to go home to die. and that's the Oregon way. We have, back when I worked at Mercy, they were always impressed that Mercy had the lowest mortality rates in the country. So CHI, big system here, and Mercy's mortality rates were incredibly low, and that was because very few people chose to die in the hospital, right? So many people had cancer, many people had bad congestive heart failure, many people had COPD, were faced with the prospect of going in the ICU, being ventilated, likely dying in the ICU, and they decided, I don't want that, and they decided to go home and die at home. So Oregon, to its great credit, has a very high use of hospice. And so the hospital death rate is really very low. Most of the people who have died have been on hospice. And the treatments they're getting there are, I think, really the up-to-date treatments. So NIH has a treatment playbook. I think almost all of the things we can do here. So I think they're getting remdesivir. In fact, some people are outpatients getting remdesivir. They're getting oxygen. They're getting high-flow oxygen. They're getting prone positioning. They're getting Decadron. If they're qualified for other things, they get the other things they get. I know our intensive care doctors here, and they are really absolutely top-notch. And so I worked at the Bethesda Naval Hospital. I worked at Mass General Hospital. And the people here in intensive care are really top-notch. So I think they're getting it. Now, there are certain things that we don't have here in Douglas County. One of those is ECMO, which is extracorporeal membrane oxygenation, basically a heart-lung machine that can keep you alive when your lungs are really, really bad. We just do not have the setup here in Douglas County, so sometimes people need to leave to do that. We also don't do a lot of chest surgery here, so that if people need chest surgery, they'll sometimes need to go to have chest surgery to place. But about 90% of the people who get hospitalized can do perfectly well in Douglas County, and I think the people in Douglas County do a really great job with that. Okay, so the big exciting thing that's out this week is the vaccines. And I tell you, I look at the primary source data for all this stuff, and the primary source data for the Pfizer vaccine came out. It is about 100 pages, and so I spent all morning reading that. It is every bit as good as it looks. It really looks great. I mean, it really looks like this vaccine is going to be 90% effective in the different groups they looked at. So they looked at people with and without underlying conditions. They looked at young people and old people. They looked at people with HIV. And what they found is that it was really pretty effective in every group, more than 90% in each group. And they carefully looked for safety things, and there were no big safety concerns. The one thing that was a little bit more common in the one group than the other was Bell's palsy, which is a relatively common thing. So there were 4 in the treatment group, and I think only one in the placebo group. But that difference is probably just explained by flip of the coin. Bell's palsy is when you get weakness on one side of the face, which is a relatively common thing, not serious. And so really no major side effects. The one thing that there was a lot of injection site stuff. So a lot of redness and soreness at the thing. A lot of people felt really crummy the next day. So maybe 50% of the people had one or more I feel crummy symptoms the next day. So that's going to be an issue. Because you don't want people who are feeling crummy working on me, and you also don't want people who are feeling crummy being at work, because they could just have a vaccine reaction, but they could also have COVID or something else. And so the likelihood is that we're going to have to carefully, when we give this vaccine, be sure that the people who are getting the vaccine are not scheduled the next day. And how work sites figure that out, I do not know. Are they going to give people a day off? Are they going to give it to them on their weekends? Are they going to do some combination of the two? I do not know, but that seems to be the issue. So the data came out today. It really looked great. So there are 2 curves. So it looks at, you go out the weeks, and it looks like by 1 week after the second dose, you have about 90% protection. And since the first dose is followed by the second dose in 21 days, by 28 days after the first dose, if you get the second dose at 21 days, you seem to have over 90% protection. That would be great. I mean, that would be really, really good. So we'll see how it goes. It looks like Oregon is going to get some of the vaccine within the next 2 weeks. The first group of vaccine is going to go to the hospital to give to hospital workers. The other first shipment is going to go to nursing homes for nursing home patients and nursing home workers. Then there's going to be another group for other healthcare workers. Those will be the 1A group. So that's going to be mostly December and January. We think by starting in January, probably through February, maybe March, we're going to be starting to immunize other essential workers, teachers, people working in the prisons, other essential industries. And then come February, March, April, we're going to start being able to do other high-risk seniors. And then by May and June, it looks like there'll be enough vaccine for the rest of the population. And so this really looks like if we can get this done, it'll be great. But what I tell people, this is really a big effort. Really, really a big effort. So we've done a lot of these drive-through flu clinics. We did 200 flu shots in one afternoon. We were like, yeah, we're great. We're going to have to do, as a county, 1,000 a day between now and June to get everybody vaccinated. So our clinics, which were really great, and they had a lot of people working in them and whatever, we did 200 a day. We're going to have to do 5 times that a day, every business day between now and the summertime. So it's going to be what I think is the equivalent of the 2020 moonshot. So when we tried to say we're going to send a man to the moon and bring him back safely by the end of the decade, this is we're going to try and get 80% of our population immunized between now and the 4th of July. So it's going to be a big thing, but I think if any county's up to it, we are it. So Beverly says, are there any updates about the coast area? Yeah, so the coast had a big outbreak in the end of October and beginning of November associated with a Halloween party. It then spread to lots of businesses over there. The people in Reedsport have done a very good job with quarantine and isolation, and the cases seem to really decrease. I have not seen a case in 4 days over there, so that is good. It looks like they may be past this, but a lot of hospitalizations, a lot of business exposures, and some deaths. So my great-granddaughter goes to the Boys and Girls Club, and her mom has COVID. Can I be around them? Ooh. Well, I mean, if you're old enough to have great-grandchildren, you must be a bit older, so you're at a high-risk group. If their mom has COVID, the risk is that the children will have COVID too. So really, if the mom is your granddaughter, yeah, I'd really stay out away from them through the isolation period. I mean, people over 70, when they get the disease, get really, really, really sick. So Susan says, how many cases in our county? How many have recovered? Now, probably said this 100 times, but we'll say 101. So the story is the definition of recovery. There's no standard definition for recovery. Unlike other illnesses where you get a disease, you get over it, and typically you get over it at the time you're no longer contagious. So for the flu, that's typically the story. So I get the flu on December the 8th. I feel crappy when I get the flu. By a week later, I'm feeling better. The disease is gone. There's no long-term sequelae. So typically the end of my infectious period and the end of my disease period are about the same. So they consider me recovered 7 days after my infection. This disease is weird, right? There are people asymptomatic, so it's hard to find a recovery date on people who are asymptomatic. There are people who are sick for months. So I don't want to say but are only contagious or infectious for 10 days. You don't want to say on the 11th day, oh, you're recovered, when they say, you don't know how crappy I feel. And so we have pretty much gotten away from the use of recovered. And I would hope that this is the last time we have to talk about this, but we've gotten rid of the use of recovered. Now, if you want to know how many people are currently potentially contagious, that would be the number of people in isolation. So there's 1,110 total cases, and there are 179 currently in isolation. So there are 179 currently active cases. Now, not all are symptomatic, but most are. And we're not saying that at the end of 10 days they're all going to feel better, and that's why we do it this way. So Margie says, why are we not talking about taking zinc, vitamin D3, vitamin C? So those things are all great. There have been no studies suggesting that they really make a big difference. However, if you want to take zinc, if you want to take vitamin D3, if you want to take vitamin C, go for it. I really go for it, because those are all reasonably easy things to get. We don't think there's any problem taking those in therapeutic doses, so please take it. So Margie also says, why are the numbers so high when we are wearing masks and not able to go places? It's because we're not wearing masks. Okay, let me tell you about the outbreaks we have. In every one of the outbreaks, there's been a major break in protocol of wearing masks. The answer is the reason the numbers are so high is because we are not wearing masks. It's the Halloween party where there was not a mask in sight. It is the church site where there was not a mask in sight. It was the church dinner where there was no masks at all. And then it was in places when nursing homes spread where there was poor use of masks. So we have it wrong. So why are the numbers so high when we are wearing masks? No, the answer is the numbers are so high because we have a break in the protocols of using masks. So I'm being told that many mills are not requiring employees to wear a mask and are not distancing. Should they be taking more precautions? Well, yes, they should be taking precautions. I've talked with a bunch of people at the mills. They promised me that they're using the precautions that you're allowed to have. Now, there are some places, there are some very specific issues about using masks in industrial settings. And so I would call them and ask them, say, are you using the masks? And if you have good evidence that they're not, Oregon OSHA is the one who does that. So how do total deaths from all causes in Oregon this year compare to the last 10 years total deaths? And so again, remember, Oregon is one of the least affected states. We've had a little blip in our overall death rate, although with 36 deaths today, we have a lot. And so there is if you look in the New York Times site, they have an excess deaths thing. In Oregon, not so much in Oregon, but if you look like at New York, South Dakota, North Dakota, they've had a lot of excess deaths this time. And so that really is something you should look at. Again, in December of 2020, the leading cause of death, I will bet you another $50, is going to be COVID. It's not going to be heart disease. It's not going to be cancer. It's not going to be accidents. It's not going to be suicide. It's not going to be homicide. It is going to be COVID, the number one cause of death. And the age distribution on these deaths is very similar to the age distribution from heart disease. You don't have very many 23-year-olds die of heart disease. You have a lot of 65-year-olds and 80-year-olds and 90-year-olds die of heart disease. Again, thank God you don't have very many 20 and 30-year-olds die of cancer. Once you start getting your 60s, 70s, 80s, and 90s, that's when you die of cancer. So the age distribution of deaths for COVID is a lot like heart disease. It's a lot like cancer, and it is going to be the leading cause of death in December. It is already the leading cause of death in November for the Dakotas. So how safe do you think the vaccine is? At least from the data I saw today, and I really scrutinized it, it looks to be frickin' safe. I mean, really, really safe. I mean, they had a lot of people in each of the groups. So many drugs are approved with just a few hundred in each group, and then they do post-marketing analysis. They had over 10,000 in each group. So this is a really very, very well-studied vaccine, and it seems to be really, really safe, except for the Bell's palsy. Really not a lot of other even moderate side effects, except for the pain and the ache that you get when you get it. So if you can get COVID multiple times, how will the vaccine be effective? I don't know. That's sort of interesting. There are a bunch of vaccines that are much more effective than getting the disease. So what I've talked about before is a disease called Haemophilus influenza B. Is Haemophilus influenza B, which you could get multiple times. And they came out with a vaccine, and the vaccine was so incredibly effective. They said, well, how could the vaccine be more effective than the disease itself? And We don't exactly know, but it does seem to be. And it may be that during the time you are infected, you have all of these different antigens that your body is trying to make antibodies to. Whereas when you get the vaccine, all of your antibodies are going towards the one antigen that you're presenting. So it does seem to be sort of a question, how could this be? But there's certainly precedent for that. So someone says, I tested positive on 11/28. That is miserable. I have had symptoms since 11/24, so about 14 days. I'm much better, but have a low temp at night. Is this something you see in COVID? It is absolutely what we see in COVID. So again, the reason we do not have recovery at 10 days is that we see a lot of people who are sick for a long time. Fevers, chest pain, cough, those kind of things go a long time. So we don't, for example, if you were a worker, we would not let you go back to work until you were fever-free for 24 hours without the use of fever-reducing medicine. So someone says, are community health workers, PT, OT, speech therapy, home health in the 1A phase? CDC was a little unclear about that. I think they will. Home health will. I don't know about PT, OT, and speech therapy. I think we're still waiting for the guidance from CDC. So John says, will OHA adopt the new CDC quarantine recommendation? The answer is yes. Actually, well, let's call this the Oregon recommendation. So a group of us graybeards, I did have a beard at the time, a bunch of us graybeards met this summertime to consider the 14 days of quarantine. We recognized at that time that the 14 days of quarantine was really problematic. So a bunch of us, I was the youngest guy in the group, so I'll tell you how old this group was, looked at the quarantine recommendations, and we made a recommendation to change quarantine to 7 days with a negative test or 10 days with no test. And after a few months, CDC has adopted the Oregon recommendation. And so I think Oregon Health Authority will adopt the Oregon recommendation today or tomorrow. And so in the past, if you were a close contact, we said it was 14 days, no way to test out of it. Now it's going to be 14 days if you're in a congregate setting like a nursing home or a long-term care facility, 10 days if you're not in those groups, as long as you're asymptomatic in both of those, or 7 days if you have a negative test after the 5th day. So let's say I get exposed on a Sunday, Monday, Tuesday, Wednesday, Thursday, Friday. If I get a negative test on Friday and I get that test result back, I can go back to work the next Monday. So I only miss 1 week of work versus 2 weeks of work. For people in essential industries, that's great. Now, that comes at a slightly increased risk. About 4% of the time, I will feel fine in that first week. I will have a negative test on Friday, and then the Monday I go back to work. That Monday night I come down with symptoms. So about 4 or 5% of the time, I will go ahead and spread that to others. And so there's a little risk associated with this, but getting essential workers back in that second week is really very useful. So Casey says, what is known about viral load? Why some have the disease and not spread it, and others are super spreaders? Casey, you will win the Nobel Prize if you get that answer. Is it about viral load? Maybe. But when they look at the viral load of the people who are the super spreaders, it doesn't seem to be that different from others. In fact, the people with the highest viral load are kids, and they don't seem ever to be super spreaders. In fact, we cannot find a childhood super spreader event. And so it's probably not just viral load, but there may be something else that goes with it, because the super spreader phenomena is truly remarkable, right? How we have had 5 of these super spreader events where one person has infected 20 to 50 people. I mean, how does that, I mean, that is just amazing. The thought is there may be something about there may be something about their viral load. There may be something about where they are, what they're doing, and how vocal they are with it. So, for example, singers, we think, spread the virus a lot more than people who talk quietly. We think people who are in crowded venues with poor ventilation tend to spread it much more than others. So people say it's something about the person who has it, but it's also about the venue and the level of voice. So I think it's pretty remarkable, and I do not know about the super spreader thing. So Whitney says, what happens if someone doesn't follow self-quarantine? Well, there are no quarantine police in Oregon. There are no quarantine police anywhere in the United States. And if somebody doesn't follow self-quarantine, goes out, they could infect others, and they could now spread it to others. And we have seen some breaks in self-quarantine where people have now spread it to others, and they spread the disease. I mean, we're really counting on people to do the right thing, which is if you are a contact, to stay home and not potentially spread it to others. Now, again, only about 20% of contacts are ever going to get the disease. So about 80% of the people, even if they went out, wouldn't spread it. But you don't know if you're going to be one of those 20%. So we're asking people to self-quarantine. So Missy asks a great question. I've heard the vaccine will be given in the same amount to every person. Why would a 100-pound person get the same amount as a 200-pound person? I don't know. I mean, this is really amazing, right? Because when we give vaccines, we'll give a flu vaccine, same dose, 6 months to 100 years. So the 400-pound guy gets the same dose as the 9-pound baby. Now, there aren't many 6-month-olds who are 9 pounds, but there could be. So the 9-pound baby and the 400-pound guy get the same dose of vaccines. And so that's the way vaccines work. So except for flu vaccine, which did have a different dose for smaller ages, which they've gotten rid of now, it's the same dose for all ages because it doesn't seem to make a big difference. So my daughter has to get a rapid test. Her one is back in 2 days to get a procedure. So will the doctor in Portland need to send an order to get that done? So if you need to get it back in 2 days, you probably need to do a rapid test. The PCR test that we were talking about before that we do at the drive-thru are now taking 3 or 4 days. And I don't think you want to predicate your surgery on that test coming back in time. So a rapid test. A rapid test is not quite as accurate. It has more false positives and more false negatives, but if you need to get it done, you'll need to do that. Any of the doctors in town should be able to do a rapid test. So, Aviva, Evergreen, Kids Docs, all those different places have the tests and they can do the rapid test. So if you have COVID and you're in the hospital, why do they put you in the same room with somebody else who has COVID? If they're sicker, could be passed to you and make you worse. We think not. So we think once you get the infection, you can't get it again for another 90 days. So if I'm in the hospital recovering from my COVID and they put somebody else in the room who's also got COVID, we do not think they can reinfect me. So that's a good question, but I don't think it's going to happen. So Christine says, what's the longest length of time antibodies are showing up after the infection? Well, the longest infections we know are from January and February, and some of those people still have antibodies. So it lasts for a while. Now, again, the story with antibodies is they get produced in huge numbers right after you get vaccinated or right after you get infected, and those numbers come down. But the next time your body sees the virus, it remembers it saw it before. It can make a huge number of antibodies again. So just the antibody levels itself are not as effective, although we are starting to see people with secondary infections. We have a couple of really well-documented cases where they actually have the virus and can show it's a different virus, so they got it again. But now there are hundreds or thousands maybe of stories of people who had the disease once. They were sick with the disease, they had a positive test, they secondarily got better, and then got sick again. And so we do think you can get it again, but it's probably not, is not all that common. So Zay says, are we seeing more children with COVID? No, we're seeing about the same number of kids with COVID. Again, almost all the kids with COVID get it from their parents. So people who tested positive are not accepted into foster homes, rehab, and nursing centers. And so this is really one of the troubles, right? So people who have COVID find it really hard to get back to the nursing home because the nursing home now doesn't want to have people in the nursing home who have COVID. It's very complicated, but I will tell you that they are working on that. We do know that nobody is contagious after 20 days. So after 20 days, after the onset of infection, you can go back to the nursing home, even if you were positive, because after 20 days, we know you're no longer infectious. But 20 days is a long time. And so what do you do with people if they're ready to go home on the 8th day from the hospital, what happens between that 8th and 20th day, and this is really complicated. So if somebody is exposed and won't quarantine, does that mean that they are exposing other people? Whitney asks. The answer is they may be exposing other people. Again, remember, if somebody's exposed, about 20% of the time they will get the disease and can expose others. About 80% of the time they will not, depending on what their exposure was. And so, yes, there's a risk you're exposing people, but not that you're definitely exposing other people. So Ambrosia asks, why are non-essential businesses still open if lockdowns are in place? So Oregon never defined essential businesses. So some states said, this business is essential, that business isn't. Oregon never defined essential businesses. Rather, what they did is they defined businesses by groups. So restaurants, bars, gyms, gift shops, and whatever else along the way. And they did that. There are some places that are still open that people would scratch their heads, like stores are open. They say, why is Lowe's still open, or Home Depot or Albertsons still open? Well, those are considered necessary for people to do the things that they need to do. And certainly if you close all the grocery stores, people would soon run out of food. And similarly, if you close some of the other big box stores, people are going to run out of stuff that they need. And so again, Oregon does not do essential and non-essential businesses. Oregon is pretty locked down. And so I think Oregon has done a good job, and I think what you see is we've had a decrease in a number of our cases. So Christine says, am I going to get the vaccine? As soon as I can. Lisa says the vaccine lifetime or annual. Again, we don't know. Again, in the data to the FDA, it did not suggest whether this would be it. I think probably what's going to happen is that they're going to give everybody the vaccine in the first round. Next summer, they're going to look at the people who got it early on. They're going to look to see what their antibody levels did, and they're going to look to see if those people in the original group are now starting to get the disease, and if they are, they might recommend a booster. But I don't think we're going to know that until next summer. So Joe says, what are the ingredients of the vaccine? I would like to know what I'm putting in my body. The good news is if you go to the FDA Emergency Use Authorization meeting held on December the 10th, and do the meeting materials, there are 2 very large files over 1 megabyte each that have it in there. And all of the ingredients, including the active and the inactive ingredients, are there. I could never remember the names. These were super long chemicals, because what they are is the mRNA spike protein, and then the mRNA spike protein is coated with a little fatty globule around it, so that when it gets in the bloodstream, the cells say, well, that looks like food, and they take in the fat globule, and by taking in the fat globule, then take in the protein. And so, Joe, take a look at it and see. So Lori says, if you get the vaccine and get the virus, is it a milder illness? So the thing that they looked at is on the Pfizer vaccine is how many people got symptomatic disease in each group. So when 170 some odd people got symptomatic disease, they broke the code and they found who was in the treatment group and who was in the placebo group. Overwhelmingly, the people who got the disease were in the placebo group, and only a few people were in the treatment group, and that's how they came up with the 95%. Then when they looked at people who were really sick with COVID, none of the people who were in the treatment group got really sick, whereas all the people who got this, just not many, were in the placebo group. So again, it not only seems to prevent you from getting the disease overall, but it also really seems to prevent you from getting severe disease. So it's great. So Clover says, how will folks get notified if they're eligible to get the vaccine? There is going to be a really big campaign to tell people about that. So Sandra says, how long does it take after you get the vaccine to be effective? So it looked like 5 days after the first dose, you started having some effect, and that by 7 days after the second dose. So the first dose, 21 days later, you get the second dose, 7 days after that, you seem to have the full level of protection. Do we know potential long-term side effects of the vaccine? Kathy asks, no. I mean, the vaccine's only been out for a few months, so we do not know about the long-term side effects. But the people who are in this group are being very carefully monitored for side effects, and 2 months out, we've not seen any. Now, I don't know about 2 years out, 20 years out, whether they'll have side effects. But if you think about the way this vaccine is done, I don't think so. This doesn't get into your nucleus. It doesn't change your DNA. It doesn't make any long-term things in your body. So I think it's going to be safe, but you only know about potential long-term side effects after you study them. So Diane says, are we noticing significant problems with secondary infections? Amazingly not. Amazingly not. So we usually think that when you get a viral illness, you start out with the flu and then you get a secondary bacterial pneumonia. We've not been seeing a lot of secondary infections. Penny says, what therapies are being used for COVID patients locally, both in and outpatient? So, the only approved therapies are remdesivir, and people are getting that. For hospitalized patients, Decadron. There are some patients who are needing oxygen who are also getting Decadron. I do not think there's anybody in town who's using the monoclonal antibodies. I think there are probably still some people getting hydroxychloroquine. There may be some people getting Luvox or Ivermectin off-label. But unfortunately, there's not really a lot of good already approved therapies. So Jamie says, my son has tested positive and can't go back until he has a negative test. How is that possible? I spend an hour a day trying to debunk that myth. Early on, March and April, the thought was that you had to have a test and a confirmatory test to make the diagnosis, and then you need to have 2 negative tests to go back to work and whatever. That is so April. I mean, really, since July, we have recognized that that is a disastrous, wasteful, and not good strategy. So Jamie, if you can send a message to us, I think privately you probably can, to Kristen, who's doing this, about where they're working and who the HR person is, I'll give them a call. So this is how the call goes a couple times a day. Hi, this is Dr. Dannenhoffer from Public Health. Can I talk to so-and-so in HR? Great. I understand you're requiring a negative test for Joe to return to work. Ooh. Yes, we are. We require 2. We're following all the CDC guidance. We'll say, great. Could you pull up the date of that? It's April 11th. Okay, great. Could you look at the most recent guidance? That is not what it says. It says tests to return to work are not recommended. And they're not recommended for a few reasons. One is people can test positive for a long time, well beyond the time they're contagious, and there's no reason to exclude them from work. The second is these tests are no fun, and they're expensive. And so negative tests make no sense at all to return to work. So, Jamie, if you could tell us where they work and the name of the HR person, I will make one of those calls too, probably tomorrow. Okay, that is what we have for tonight. It is getting late, so we'll call this a night, and we'll do this again on Friday at 4 o'clock. Again, if you have questions, if you put them into Facebook questions at Public Health Network, DouglasPublicHealthNetwork.org. We'll gather those and do those first on Friday, but then we'll also take your questions. These are all great questions. We'll keep doing those. I usually look through these. If there are other questions that were in there that I didn't get to, I'll try and answer those. But again, we are at an incredible time. We have a vaccine that looks to be very safe, that looks to be very effective, and is really our way out of this pandemic. However, it is going to take until the summertime to get enough vaccine and to vaccinate enough people to get us there. And so what we're asking people is to hold on for the 4th of July, continue to, I know we hate to do it, wear masks, socially distance, stay away from other people. But if we can keep this disease down to a dull roar between now and the springtime, we can get through this without the 30 some odd deaths we had today in Oregon. That is really, really disheartening to see that many deaths, but I think we can do it. I think Douglas County has shown we could do it. So there was a little bit of bad behavior at the beginning of November, which caused us to have a bunch of cases. But since then, people have really, really done a great job, and thank everybody for that. So Again, the big place where we see it, and so we'll get back to the question is, well, we're all wearing masks. How come there's so much disease? The answer is we are doing a good job of wearing masks at places like the grocery store. I mean, I was at the grocery store the other day. I don't think I saw a single person who is not using a mask appropriately. That is great. And that's why we see very little spread at the grocery store. However, we are still seeing spread at Thanksgiving dinners where people took down their masks, had dinner with somebody else. Now, again, that's going to happen, but the more people you have, the more risk of spread. At church meetings, at church socials, at work where people take their masks down during break, that's where we've seen the spread. So the one thing I would ask is, if you're going to be around other people who are not in your household, please, please, please wear your mask and try not to gather as best you can. Again, this is Dr. Bob Dannenhoffer, Public Health Officer in Douglas County. Thank you, and I will see you again on Friday. Bye-bye.